and from the Department of Medicine from PSG Institute of Medical Science and Research. We have the Dr. Sujaya Menon, the Professor and Unit Chief of Department of Medicine. Really thank you, Madam. Welcome, Madam, for this joining this evening program.
Okay,
And
thank
we
you,
have,
Shamina.
yeah, Madam, you better than, I think
I've
it's
switched,
echoing.
I've switched off the phone.
But even then it is connected, still connected and it is echoing, Madam.
Okay,
Because
now what
you
do
have
I
to
do?
disconnect from one device, Madam. Disconnect from one device.
Okay,
The link is,
what I'll do is I'll switch off my phone totally.
but even then, the system is showing that you connected through two devices.
No, I'll do it. 1 second.
Yeah.
Madam, you will have to connect only from one device, madam. You are connecting from two devices. You will
Now,
not be able to
is
speak,
it
madam.
better?
No, no, madam. You are from two devices still.
No,
You will have...
I've switched off the phone.
No, madam. I can see you connected from two devices, madam.
Yes, Madam. Two devices. Name
It
is
will not work,
displaying
ma'am.
here.
You will have to
Yeah.
disconnect from one device.
Um,
Without that, it will not work, ma'am.
the phone is totally switched off. What other device could it be?
No
I
idea,
have
madam.
used
We
my
can
laptop.
see you from...
Madam, the device, I think your phone.
Now try,
Yeah.
madam.
Now you try, Madam. It is okay. Now only one device.
I have
Yes.
removed that another one. I don't know which device it is, but I have removed it, madam.
Okay, thank you.
Yeah, now it's okay, Madam. Only one device we have to connect. Otherwise, echoing will happen.
Right.
Yeah, sorry. And it's my pleasure to welcome Dr. Varun, the Associate Professor of Department of Pulmonology with us. Really, Dr. Varun, for thanking you for joining us today and being the
Good evening,
faculty
sir.
for this.
Thank you.
Yeah,
Thanks for the invite, sir.
yeah,
Thank you,
yeah.
sir.
And we have with us Dr. Lakshmi Priya, the postdoc from Department of Medicine, is going to present a case on approach to respiratory system. Over to Dr. Sujaya Menon and Dr. Varun and Lakshmi Priya to take over the further proceeding this session and discussion on this topic. Thank you.
Thank you, sir.
Right. Yeah. Start, Lakshmi. Yeah.
Okay, sir. Okay, ma'am. Good evening, everyone. Today I'm presenting a respiratory system case. 79-year-old lady, Mrs. C, residing in Karur, farmer by occupation, belonging to lower middle socioeconomic class as per modified Kopasamy classification, came with chief complaints of cough with expectoration for 1 year, which has worsened since the past 20 days, breathlessness for 2 months, malaise for 10 days, and weight loss of 3 kg over 1 week. The patient was apparently asymptomatic 1 year back, after which she had complaints of cough with expectoration, which was insidious in onset, worsened since past 20 days, which was aggravated on lying on right lateral position, with no diurnal or seasonal variation, no relieving factors. This was associated with expectoration, which was thick, mucoid, white in color, with approximately 30 to 40 ml per day, non-blood tinged. Complained of breathless on exertion for the past 2 months, which was insidious in onset, progressive from grade 1 MMRC to grade 2 MMRC over the past 15 days, relieved on rest, not associated with chest pain, orthopnea, paroxysmal nocturnal dyspnea. She has malaise for the past 10 days and a history of unintentional weight loss of 3 kg over past 1 week. No history of fever, decreased appetite, evening rise of temperature, night sweats. No history of nasal discharge or nasal congestion. No history of atopy. No history of wheeze or regular nebulization usage. No history of bloating, burning epigastric pain or regurgitation of food. No history of yellowish discoloration of eyes, skin, any abdominal pain, vomiting or low stools. No complaint of leg swelling, facial puffiness or decreased urine output. No history of rashes or joint pain. No history of hoarseness of voice. No history of recent travel or sick contact. Patient had a history of coming to the past history. Patient had a history of recurrent fever with throat irritation 2 years back, for which she received intravenous injections on OPD basis. Details are not available. She had a period of blood thin sputum production 10 months back, lasting for 1 week, which was relieved after oral medications. Patient then consulted a pulmonologist, and on evaluation, she was informed to have lung disease, for which she was prescribed medications for 6 months, with details which are not available. She has a history of negative medication intake for left knee pain 2 years back. No history of COVID infection, no history of contact with tuberculosis patients, not a known case of type 2 diabetes, systemic hypertension, ischemic heart disease, or seizure disorder, No history of surgeries or blood transfusion. She has not received any COVID vaccinations. Family history: the patient is born out of non consanguineous marriage. Mother passed away at age of 41 years due to cancer. Details are not available. Personal history: mixed diet, decreased appetite, disturbed sleep, bowel and bladder habits are unaltered. She has no addictions. Occupational and exposure history: she is a farmer by occupation for the past 50 years, discontinuous in the past 20 years. She predominantly deals with coconut trees and rice paddy fields. She has a history of biomass fuel exposure, history of pet rearing present, and history of firewood usage is present. Menstrual and obstetric history: she's parity 3 in live 3 children, full term normal delivery, no obstetric complications. Age of menarche at 13 years and age of menopause at 55 years. Coming to the summary, a 79-year-old lady with known comorbidities, non-smoker, farmer by occupation, presented with complaints of cough with thick mucoid expectoration for the past 1 year, which has worsened since the past 20 days, progressive breathlessness since the past 2 months, grade 2 MMRC, malaise for 10 days, and unintentional weight loss of 3 kg over past 1 week. To my provisional diagnosis after this history, the probable system involved is respiratory system. Anatomy involved include airway, probable parenchyma. Etiology predominantly infective, can be malignancy. Pathology, bronchiectasis, obstructive airway disease.
Right.
No.
Go ahead.
So can we, so coming back to the history, exam
Yes.
point of view, you should describe cough and recent worsening, you said, no? Past 20 days.
Yes, sir. Yes,
In
sir.
terms of what? Is it increase in intensity, increase in expectoration? Can you explain it a bit more?
The cough was initially of white scanty expectoration, sir, which was
Yeah, can you go to
predominantly.
that particular slide?
Yes, sir. So initially, she had a cough which was insidious onset with no particular positional or diurnal variation, sir. But for the past 20 days, she has noticed that it has aggravated on the right lateral position, and which was initially thick mucoid white in color. Now she has noticed an increased quantity, sir.
So there is increase
Hello, sir.
in the past 20 days, is it? Interruption.
Yes, sir.
So you mean to say that there is increase in expectoration over the past 20 days, right?
Yes, sir. Yes, sir.
Okay. So can you tell me some causes of chronic?
Sorry, sir. Your voice is getting cut, sir.
Can you tell me the causes of chronic cough with expectoration,
Yes, sir.
which means chronic
Can
productive cough?
yes,
I
sir.
hope I'm audible, right?
Yes, sir. The voice got cut, but I got your questions. Chronic cough can be it can be an obstructive airway disease, COPD, chronic bronchitis. Then it can be, considering the infective part, it can be tuberculosis, sir.
Okay.
And then any malignancy with considering the prolonged history, sir.
What is your final
Okay.
diagnosis in this patient?
This patient is having a considering the chronic history, I would want to rule out an probable airway disease, sir, disease, ma'am, with
No, you haven't
infected
mentioned that
patch.
for your when
As
Mr.
if
Varun asked you about causes of chronic cough.
Yes, sir.
differential, yeah.
What have you left out?
Mm. Any other interstitial lung disease or any
Is that
upper
usually
airway
productive?
nasal drip?
No, interstitial lung disease, will you be getting a productive cough or
Is it
dry cough?
usually productive?
Yes, ma'am. Yes, sir.
ILD, yeah?
No, sir. Productive cough
No.
won't be there, sir. Dry cough only will be there.
Okay, so
So,
so
with
that's what
productive cough,
you.
maybe prolonged postnasal drip or an upper respiratory involvement.
Mm. Okay, so bronchiectasis, chronic sinusitis.
Yes, sir.
Okay, so any malignancies also can have chronic productive cough.
Yes, sir.
So then, can you tell me some causes of dry cough, chronic dry cough?
Interstitial lung disease, sir. any occupational related lung disease, a few of them, and drug usage due to maybe AC inhibitors, or it can be
Okay.
it's the regular habit cough syndrome maybe.
Mm. What about other gastrointestinal causes? Are there any
Yes,
gastrointestinal?
yes, ma'am. Gastric reflux can also cause a prolonged chronic cough.
Can bronchial asthma give rise to non-productive cough?
Yes, ma'am.
What's that called?
No. A cough variant asthma.
Cough variant. Okay. Right. In your system review,
Yes,
uh,
ma'am.
so you should work backwards. So, what else do you think are the systemic causes for this patient's condition, which you have not sort of touched on? Can you go to that relevant slide?
This one, ma'am.
No, your negative history. Yeah. V, zeta B, all that's fine. But what have you left out?
Considering her dyspnea, first we have to rule out whether it is cardiac versus respiratory.
Yeah,
He
that you
was
have
choosing.
mentioned, right? Somewhere I
Yes, ma'am.
think.
Yes,
You
ma'am.
said, yeah,
Initially, I had mentioned.
yes, is mentioned. Yeah, anything? What have you left out? That's what I meant. Have you realized?
Renal is there, abdominal pain.
Hmm. Basically, your diagnosis is bronchiectasis. You said, right?
Yes, yes, ma'am.
Possibly, right.
Possible.
So, what are the causes of bronchiectasis in an 80-year-old?
Uh, 80-year-old, uh, recurrent
Okay, what are the
infection.
causes in a 20-year-old?
20-year-old, we can we have to consider the syndromes and cystic fibrosis, ma'am.
Okay, cystic fibrosis. Then
Yes, ma'am.
what else?
Any congenital syndromes, ma'am?
Yes, like.
Uh, yeah, males, Cartagena syndrome, immotile
Hmm.
ciliary dyskinesia,
Hmm.
Young syndrome.
Hmm.
In ladies, Lady Wintermere syndrome.
What else is possible in a younger individual? Any congenital deficiencies?
Alpha 1 antitrypsin deficiency, ma'am.
Hmm. So, what are the causes in an 80-year-old? This lady has been well till
Yes,
1 year or 2 years ago or something, right?
yes,
So,
ma'am.
what are the other causes?
Can an underlying COPD also can
Okay.
eventually lead
You,
to
you did
bronchitis?
mention that history of biomass. What else? A lady, adult. Okay, 80 is a little old, but yes.
Uh, Malignancy, I'm not
Hmm.
sure whether can lead to
Anything
bronchitis.
else? Anything else? What about connective tissue disorders?
Yes, ma'am.
Yeah,
Rheumatological
because
diseases.
you don't, you mentioned somewhere just rashes and joint pain. Yeah,
Yes, ma'am.
you did mention that, but you sort of haven't enlarged because you went up. You in the history you also said some alternative medicine for knee pain.
Yes, ma'am. Yes, ma'am.
Hmm?
She had left-sided knee pain 2 years back, ma'am, for which she had
So what
taken
is
a.
more likely? Knee pain at this age?
It can be osteoarthritis, ma'am.
Yes, that is more likely, right? Yeah.
Yes, ma'am. Yes, ma'am.
What kind of joint involvement is likely to cause this patient's respiratory symptoms?
Uh,
You get my question?
yes, ma'am. Yes, ma'am.
Association of joint pain with her respiratory symptoms.
Smaller joints involvement
Okay,
comes
what
from rheumatoid arthritis.
what connective tissue disease?
Rheumatoid arthritis.
Rheumatoid arthritis. Anything else?
Uh, Maybe systemic sclerosis. I'm not sure.
Sjogren's,
Yeah,
SLE.
Sjogren's, yes, ma'am. Yes, ma'am. SLA, ma'am.
Okay, sure. So
Okay.
that's just something that you should sort of also look into. Yeah, go ahead.
So
Varun,
you
you want
said,
to ask? Yeah. Yeah.
yes, ma'am. You said the patient has a postural variation, right?
Yes, sir.
So can the patient have a localized bronchiectasis? Can you tell
It
me
is
some causes of
possible.
localized bronchiectasis and some
Yes.
history which can give you a suspicion of localized bronchiectasis?
History, so any localized pain or over one side, which is indirectly causing a pleuritic irritation, and
Okay.
prolonged in when the patient is lying on the side opposite to the pathology, due to the increased drainage of secretions, she will have prolonged more cough with expectoration on that side.
So
Then causes
if there
can
is
be,
something that is obstructing the airway,
yes, sir.
that can give rise to retention of secretions resulting in bronchiectasis.
Yes, sir.
So
So can
even
be
malignancy, any
endobronchial, yes,
tumor,
sir.
yeah, any endobronchial
Yes, sir.
tumor can cause post-obstructive bronchiectasis.
Yes, sir.
Any history, especially elderly female?
She has a history of weight loss, sir.
Mm.
Other than that, the
No,
considering her age, the prolonged history, and yes, sir.
yeah. So see, any foreign body aspiration also can cause
Yes,
post-obstructive bronchiectasis.
yes, sir.
So you should ask for history of aspiration as well.
Aspiration. Okay, sir.
Okay. And
Okay,
one thing regarding your history, you have mentioned that it
yes,
is for the past 1 year, right?
yes, sir.
So, but
The
but in the past history, you have mentioned about history of
Yes, sir. One,
hemoptysis.
yes, sir. Her
Will
complete point of symptoms started 2 years back, sir, when she had a recurrent fever with throat irritation. But we don't
okay,
have any particular details on that, sir. She told
okay.
recurrent fever with throat irritation, and she had received IV injections on OPD basis.
Mm-mm.
Then she had 1 week history of blood thin sputum, so which she told that
Now
she
that's
resolved
what.
with.
See, this is 10 months back, which is within the period of 1 year. What you told in your presenting
Uh,
complaints.
yes, sir. This was in more than 1 year back. I think that's what I meant. Like in the that second year,
No,
two
no. You
years
have
back.
said you mentioned 10 months ago, no?
Yes, sir.
So which means it is still within the 1 year period, right?
Yes, sir. Yes, sir.
So which means this has to be mentioned in your history of presenting illness
Presenting
rather
illness.
than putting up it in the past history.
Past history. Okay, sir.
Okay, so anything before 1 year, if she was asymptomatic, then you can tell that in the past history.
Okay,
Whereas
sir.
this particular thing, this was well within the period of one year, so it should be mentioned in the history of presenting illness itself.
Presenting illness. Okay, sir.
Okay,
Okay,
so
sir.
like you mentioned that, and again, so 10 months back, she was diagnosed to have something for which she has taken medications for 6 months.
Yes, sir.
Which means till 4 months back, she was taking some medicines.
Taking some. Yes, sir.
Okay, so what type of medicine it could be?
On probing,
Mm.
when on probing, she's not sure, sir. It was she told it helped bring out her expectation. It relieved her cough. That's what she told, sir. Specifically for urine discoloration, she said she passed yellow discoloration. So I'm not sure. Can it be? It might be TB medication, sir, but we don't have any details per se. So
Okay, so what are the history that will favor that these medications were of ATT?
we can ask for discoloration of urine, sir. Any
Okay.
orange discoloration, any medicines which she has been taking from a strip regularly at the same time,
Okay.
and regular OP visits, and maybe
Okay. So if it was 5 years ago, 5 to 6 years
yes,
back,
yes, sir,
which means if the past history is 5, 6 years ago,
yes, sir.
what other history would favor that the patient has taken a TB medication?
Um,
Under
So
the national program.
yeah. So earlier it is
1.5
under
year,
RNDCP, right?
yes, sir.
So they used to give ATT for on
Medication.
alternative days.
Yes, sir.
Okay.
Okay, sir.
So and same strip it has to be taken, and now it is all fixed drug combination.
Yes, sir.
So based on the body weight, the number of tablets would vary. So you should
Yes.
ask if the same type of tablets, two, 3 tablets, depending upon her body weight, was prescribed. So that would
Okay,
suggest
sir.
that the patient was taking ATT.
Okay, sir.
Okay, fine.
Okay, sir. Yes.
Yeah, please proceed.
Yes. Coming to the general examination, after obtaining consent, patient was examined in a well-lit room in supine sitting and standing posture. Patient was adequately exposed from neck to pubic symphysis. Patient is conscious, oriented, and comfortable and sitting, standing in supine posture. She had a height of 135 centimeter, weight of 47 kg, with a body mass index of 25.8. Her vitals, pulse 80 beats per minute, regular in rhythm, normal volume, no specific character, no vessel wall thickening, no radio-radial or radio-femoral delay. All peripheral pulses felt equally. Blood pressure 120 by 80 millimeter mercury, measured in right upper arm in semi-recumbent position. Respiratory rate regular, thoraco-abdominal type with no usage of accessory muscles of respiration. Oxygen saturation 95% in room air. Jugular venous pulsations not visible in semi-recumbent position. Pallor present. Heart swellings present over bilateral distal interphalangeal joints, non-tender. No warmth, redness, ulnar deviation is present. No icterus, clubbing, cyanosis, pedal edema, or lymphadenopathy. No external markers of tuberculosis. No external markers of malignancy. No signs of respiratory failure. Coming to the proper system examination, respiratory system examination. On upper respiratory tract examination, external nose anatomy is normal, no nasal flaring, nasal septum central in position, no nasal bleed, discharge, polyps or turbinate hypertrophy, no sinus tenderness, gum, buccal mucosa, lips and tongue was normal, dental caries present, no halitosis or oral thrush, no tonsillar enlargement, posterior pharyngeal wall normal, there's no congestion. On lower respiratory tract system examination, inspection, chest wall is symmetrical. Spine examination, kyphosis in dorsal region was noted. Trachea appears to be midline in position. Apex impulse was not visible. No visible scars, sinus or pulsations. No intercostal introit. Respiratory movements were predominantly equal overall anterior and posterior chest. I confirmed my findings on inspection by palpation. There was a kyphosis over the dorsal region. No tendernesses was noted. Trachea was midline in position. Apical impulse was felt in the fifth intercostal space, half-inch medial to mid-clavicular line. Coming to the measurements, transverse diameter was 27 centimeter, anteroposterior diameter was 21 centimeter, transverse diameter by anteroposterior diameter was 1.25. Chest circumference on expiration was 84 centimeter and inspiration was 88 centimeter. Right hemithorax was 42 centimeter, left hemithorax was 42 centimeter. Chest expansion was 6 centimeter, which was within normal limits. The spinoscapular distance on the right side was 14 centimeter, on the left side it was 13 centimeter. Spinoacromial distance was 21 centimeter on the right side, and on the left it was 21 centimeter. I confirmed the respiratory movements, which were predominantly equal except on the infrascapular region. On the left infrascapular region, respiratory movement was decreased. Vocal fremitus was felt in all regions. However, it was reduced in the left infraaxillary, and left infrascapular region. There's no tactile or friction fremitus noted, no tenderness over the chest or back, no rib crowding, no pony tenderness. On percussion, a resonant note was heard over the most areas except in the left mammary, infraaxillary, and infrascapular region. Left mammary dull note was noted, and on infraaxillary and infrascapular, a stony dull note was elicited. There was no shifting dullness, straight line dullness, or succussion splash. On tidal percussion, a dull note was elicited in the fifth intercostal space, which turned resonant on full inspiration. Throb space was dull on percussion. Chronic isthmus was resonant. The right heart border was along the right sternal border. However, the left heart border could not be ascertained. On auscultation, vesicular sounds were heard in the most auscultatory areas, except towards the infraclavicular and left infraclavicular and left mammary and left infrascapular region. There was decreased in intensity of the breath sounds. Vocal resonance was reduced in the left infraaxillary and infrascapular region. Coarse crepitations were heard over all auscultatory areas over the right lung and of lesser intensity over the left lung. No bronchophony, echophony, or whispering pectoraloquy was elicited. Coming to other system examination, cardiovascular system, S1, S2 is heard over all auscultatory areas. No murmur was noted, no loud P2. Per abdomen was soft, non-tender, no organomegaly, hepatocellular reflux was normal. Central nervous system, there was no apparent focal neurological deficit, no flaps. Final diagnosis is a bilateral bronchiectasis with left-sided pleural effusion, probable infective etiology with no evidence of respiratory failure or cor pulmonale.
So, can you?
Sorry. Go ahead,
Yes,
Varun.
ma'am. No, no. Can you summarize the positive findings alone?
Yes, sir. On inspection, the patient was moderately built in nourisher with pallor, and she had no accessory muscles of usage of accessory muscles of respiration. On inspection, there was a mild kyphosis, sir, and on palpation,
Can you tell me how can you tell me how kyphosis is related with this current scenario?
um,
Is it
sir,
can you make it out that whether it is acute or a chronic kyphosis?
uh, not sure, sir. Probable
So
Okay, what
what is
kind
a
of
gibbous?
skeletal deformities give rise to respiratory problems? I mean, in
scoliosis.
the chest. Yeah.
Exaggerated kyphosis is noted in emphysema, sir. And
Okay.
scoliosis can
Exactly.
cause restriction of chest movements, so that in turn can cause breathing difficulty and decreased lung capacity.
Okay. What is a gibbous deformity?
It is a nodular deformity seen in the spine due to
Hmm.
tuberculosis
Of the
of the spine,
tuberculosis
the
where?
parts of the
Of,
spine.
of the spine. Okay, what
So
else can cause respiratory compromise? What skeletal deformities can cause respiratory compromise?
The deformities of the chest can cause reduced expansion, ma'am, like sternum, pectus carinatum, pectus excavatum.
Hmm.
Then, in case of emphysema, there is a barrel-shaped chest, ma'am.
Okay, what about ankylosing spondylitis? What happens there?
Yes, ma'am. There's restriction of the due to the rigidity of the
So
spine.
when
There is
you're asked
restriction to
a
the
question, you must not necessarily in this patient, but any other patient also. When you're
yes,
asked what deformity, what are the respiratory problems associated with, you must answer everything. You give it.
ankylosing.
Yeah.
Yes, ma'am. Yes, ma'am.
Okay. So why are the you said there are you didn't your diagnosis should be complete. So she has anemia. There are some findings in the hands. You at least you've noticed.
Yes,
What
ma'am.
do you think those
Yes, ma'am.
findings are due to?
It can, considering her history of left-sided knee pain, ma'am, it can be due to osteoarthritis.
Okay, osteoarthritis.
Yes, ma'am.
Why do you say osteoarthritis rather than rheumatoid arthritis?
It's fitting. She's having a single joint involvement,
Oh,
and still, she didn't particularly mention any history of small joint pain or early morning stiffness, ma'am.
okay.
And
And you
considering
described nodules in what area? Where were the
dist-
nodules?
distal interphalangeal joints, ma'am.
Okay. That is more a feature of
More a
which
favor of osteoarthritis, ma'am.
orchitis.
Because
Can you
yes,
get proximal interphalangeal joint involvement in osteoarthritis?
yes, ma'am. Bouchard's,
Bouchard's nodes, yes. The other
Bouchard's,
ones are known as
Herberdin's notes, ma'am.
Abedin's nodes. Okay.
So how is it different from hypertrophic pulmonary osteoarthropathy? That
Hypertrophic it, involves the forearm bones more than the joint, sir.
okay,
And there can be skin discoloration over the.
okay. So generally it'll be painful swelling, and also they
Yes,
can have clubbing. I mean they will have clubbing.
clubbing. Yes.
So, this lady, what is against bronchitis?
Uh, so, ma'am, history-wise, there was no. She didn't particularly mention about any foul-smelling, copious amount of sputum production.
Hmm.
Then other typical histories of bronchiectasis like early morning excessive sputum production. She didn't mention, ma'am. Then on examination, Examination was fitting more or less to bronchiectasis.
Okay. What in the general examination is missing? We
Yes, ma'am.
always teach
Yes,
undergraduates, but
yes,
in this patient, it doesn't seem to be there.
yes, ma'am. Clubbing was not
Clubbing is not
ma'am,
there.
yes.
Okay.
So you mentioned that the classical symptom of copious expectoration is not there in this bronchiectasis,
Yes,
right?
yes, ma'am. Yes.
Uh, so can you tell me where patients will not have expectoration at all in bronchiectasis? What do you call that bronchiectasis as?
So bronchiectasis sicca,
Okay.
where there will be decrease, there will be almost scanty sputum production, but patient presents with hemoptysis. It is
Mhm.
seen in apical tuberculosis.
Okay. So this patient had hemoptysis.
Yes, sir.
So
It can be, sir.
so that so involvement of upper lobes will be the most
Apical
common site.
lobes.
Yeah. Yeah.
Yes.
Okay.
Why on examination you mentioned chronic isthmus? What does that tell you?
Yes. Chronic isthmus is a band of resonance, ma'am, in the upper lobes, upper region of the chest. It is bounded anteriorly by the posterior border of clavicle, posteriorly by the anterior border of trapezius, medially by the neck muscles, scaleni muscles, and laterally by the acromioclavicular joint. It's usually resonant. In cases of apical tuberculosis, Fancos tumor, a dull note is elicited over the chronic isthmus.
So here you don't think it is
No,
apical
yes.
involvement.
Yes, ma'am.
Okay.
Yes.
So what else from the etiology point of view? What else could have caused this bronchitis? You think?
Uh, infect besides infective, ma'am,
No. If is it infected?
it can be infective because of the previous history, ma'am.
What is the
Can be
previous history?
that history of recurrent respiratory infections
Okay.
and tuberculosis. We still have not rolled out. We're not sure whether she suffered or not.
Okay.
Um, then she has history of.
You mentioned oral thrush. Why? Why is that important? I mean, that may be important.
Ma'am, she might be immunocompromised.
Okay.
HIV
Any
can.
other reason for a respiratory patient to have oral thrush?
She has a history of this medication, alternative medication intake, which might have steroids or any chronic
Okay,
steroid use.
that's
We are
one.
not sure.
Assuming she didn't have any alternative medicine, can allopathic medicines cause oral thrush given for a respiratory patient?
Yes, ma'am. Because of frequent exacerbations, she might be prescribed oral steroids, ma'am. So that
Oh,
chronic
besides
use.
oral steroids, inhalation. What about inhalation?
Yeah, yes, ma'am.
You did mention she was never prescribed nebulizer and all that.
Yes, ma'am. Yes, ma'am.
Huh?
Yes, ma'am.
Okay, right.
So in the inspection, you said the chest movements are diminished, right? Inspection and palpation, you said the chest movements
Yes,
are diminished.
yes.
So can you tell me the points which are against collapse or fibrosis? Because
Uh,
you're told that it is pleural effusion.
yes, sir.
Tell me what are the other conditions where the chest movements will be reduced?
Chest movements will be reduced in case of fibrosis collapse also, sir. However, there was no evidence of any volume loss or any rib crowding in that region. Moreover, vocal resonance
Start
also.
from no. Start from inspectory
Ins-
findings.
okay. Inspection, there's no evidence of volume loss or any drooping, but drooping of shoulder, any
Hmm.
signs
So
of.
Trachea.
here in
What
the
about
chest,
trachea?
Yes,
What
ma'am.
happens
Trachea.
to
Yes, ma'am.
trachea?
Trachea. Yes, ma'am. Trachea gets pulled to the same side, ma'am. If the left-sided fibrosis or collapse, so there is no tracheal shift,
Hmm.
and there is
uh,
no apical impulse is also felt in the fifth intercostal space, ma'am. So lower mediastinal shift is also not there, ma'am. And on palpation, when we look for rib crowding, there is no rib crowding.
Hmm.
okay. So
Then
was there any intercostal tenderness?
no, sir.
Why is that important?
Uh,
Where do you get intercostal tenderness?
in in, um in pleurisy, costochondritis,
No, no. In
Hmm.
the setting of
in the setting
Dr.
of.
Varun is asking in the setting of decreased You said pleural effusion,
moment,
but
yeah.
there is intercostal tenderness. What is that? What does that make the pleural effusion?
Any malignancy?
Cha 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 cha. Okay, okay. Malignancy, maybe involvement of the pleural. Okay, but anything else? Tenderness with a pleural effusion. What is that? Equal to?
What kind of pleural fluid
Pneumothorax.
characteristics it will be?
Pneumothorax, sir?
Eh?
No.
Pneumothorax. What are you
Because
saying? No,
That
no.
that is more of
What
chest pain,
fluid
right?
pain? When there is
Yes,
so
sir.
much tenderness, intercostal edema, what kind of effusion would it be?
Any effusion, if it is not treated for a prolonged time, what can it become?
A loculated effusion.
Hmm.
Okay, then
What are the signs of inflammation,
Infections,
ma?
empyema,
Signs of inflammation.
yeah, that's what.
Empyema. My God, we had to pull
So,
teeth out of you. Hmm.
mm.
Okay, go ahead.
so, so you said pleurisy, right?
yes, sir.
So, can you tell me one particular sign which would suggest pleurisy in auscultation?
Pleural rub, sir.
Okay.
It's
How do you differentiate? That's an added sound, right?
yes, sir.
So, any other sound that mimics a pleural rub?
Even crepitations can sound similar to coarse crepitations can sound similar to pleural rubs, sir.
Okay.
But pleural rubs will be more localized, sir.
Hmm.
And crepitations, it can persist irrespective of the position or any change in cuffing. The pleural rub will persist, while crepitations can clear.
Okay.
And then other symptoms of pain, tenderness will suggest more of
No, in auscultation.
auscultation.
Hmm.
Um, I think this both face
Yeah.
crepitations will have inspiratory and expiratory, can have expiratory or inspiratory variation, but pleural rub will be present in both phases
In
of.
both the phases. Okay. And once you apply pressure, no?
Yes,
So
sir.
the intensity of the sound would increase in a pleural rub.
Pleural rub, yes,
And
sir.
of course,
What
it will be
other
associated.
rub can you hear?
Ma'am?
Say on the left chest, what other rub can you hear?
For this patient, ma'am?
Not this patient, I'm just saying
Oh,
any patient.
okay. It can be a pericardial rub also, ma'am, left-sided.
Okay. And how will you differentiate a pericardial from pleural rub? Hello, am I audible?
Are
Hello?
you,
Yes, yes, ma'am.
Yeah.
so how do you differentiate a pericardial rub and a pleural rub?
Pleural rub.
Pericardial.
One of the questions we often ask in history is pleuritic chest pain, right?
Chest pain, yes,
What
ma'am.
is pleuritic chest pain?
It's a sharp, pricking type of pain, which is aggravated on inspiration, prolonged
Right.
talk.
So it is related to breathing movements. So that's a
Yes.
clue I've given you. So how will you differentiate pericardial from pleural rub?
Uh, on I think on deep, on deep inspiration, this rub will
So
not.
basically, when the patient is taking deep breath,
Yes,
the,
ma'am.
both the visceral and the parietal pleura are getting rubbed against each other.
So how
Yes.
will you prevent that?
By asking the patient to hold breath, and then
Hold breath. Yes. So what
yes,
happens to the pleural rub?
that will
The,
be no, pleural rub won't be heard.
Will not be heard, whereas a pericardial rub will
Pericardial rub will be heard.
continue. So that is
so,
the differentiating feature.
yeah, and
Yes.
that will be synchronous with the heartbeat.
Hmm.
Yes, ma'am. Yes.
Okay. So
Yes.
in any other auscultatory finding which can be synchronous with the heartbeat, can you tell me?
Auscultatory finding.
Yeah, auscultatory finding. This, I'll give you a clue also. This can be present in a pneumothorax or pneumomediastinum. Okay, I'll just tell you, it's called as Hammond's crunch.
Hammond's crunch.
Okay, so
Okay,
if
sir.
there is a pneumomediastinum or a localized pneumothorax, with every
Yes, sir.
heartbeat, there will be a crunching sound. It's called as Hammond's
Okay.
crunch.
Okay, sir.
Okay.
Okay,
Right.
sir.
What else?
What is a tracheal tug, Lakshmi?
Tracheal tuck is due to any pathology like collapse fibrosis. There is a shift of trachea towards the seam side.
That is tracheal deviation. No, that's not what I
Tracheal tuck.
meant.
Okay. Ma'am, is it the upward movement of the trachea elicited on due to aortic aneurysm?
It's a downward movement, not upward. Eh?
Aortic
Downward.
down. Yes, ma'am. Downward movement. Yes, ma'am.
Downward.
Downward movement.
Right.
Oliver's
What
sign.
else? Oliver's sign. That.
Yes.
Then
But Lakshmi, what is Campbell's sign?
Campbell's sign is so,
This is homework to you.
yes.
As you said, Oliver
The
sign.
opposite. Yes, sir.
No.
I think it's
And other than these two, just point
Yes.
to add regarding the pericardial rub, also
Yes, sir.
can have a variations with the position of the patient. It is not like respiratory variations or the cardiac synchronizing with the cardiac activity. You can also get change in the nature of the rub, and the pain nature also varies with the patient's position. Okay.
Yes, sir.
So the pain is more of postural variation along with the respiratory variation, synchronizing with the cardiac activity, and the site of pain also deciding about whether you're dealing with pericardial pain or the pleural pain. Okay.
sir.
Yeah.
Okay.
And the important point that Varun has brought out is Hammond's sign or Hammond's crunch also. That
Yes.
is mediastinal signs. When you're going to deal with the problem of respiratory system, it's not going to be exam point of view, at least practical point of view. You should know, are we dealing with a pleural disease, airway disease, parenchymal disease, or mediastinal disease, or combination of any one of these structures can be combined together to have the presentation of the patient, for which you should know how to elicit these clinical signs to arrive at diagnosis at the bedside. Then only you're planning for investigations, for which you should know about the Hammond sign as well as the aortic aneurysm related, arch of aorta related, the tracheal trug sign also should be knowing about. Yeah.
Okay.
Yeah. Okay. Over to the faculties, please.
So, what do you mean by dynamic auscultation?
It's various maneuvers which we can ask the patient to do to increase the to help us appreciate the sounds, predominantly in heart sounds and murmurs. We can ask certain maneuvers
give
which the patient
examples. Give examples.
ma'am, like we can ask the patient to squat or do Valsalva maneuver to increase the intensity of murmurs on the right side. And yes, ma'am, and isometric hand grip.
Hmm. Okay.
In lungs? I mean, in the respiratory system?
Respiratory system.
Give an example.
So you said on one particular side the crepitations are more, right?
Yes, sir. Yes, sir.
Which side is that?
Crepitations, sir.
Ah,
Crepitations were heard in both lung fields, sir, but right was more than left.
okay. What could be the reason?
One could be because the maybe the lung involvement was more in the on the right side. Second was that pleural effusion uh, might have dampened the breath sound, sir.
Okay. Other reason could be
Mhm.
secretions in the airway.
Okay, sir.
So one dynamic auscultation would help you to clear this doubt. What is
Yes,
that?
yes, sir. Cough, post-tussive crepitations.
Yeah, ask the
Okay.
patient to cough and then see if the intensity of the sound is same.
Yes, and even
What?
we can ask positional variation. We can ask the patient after sitting to lie in the supine position,
Mm.
and after 3 minutes, if you're able to auscultate crepitations, it's seen in heart failures.
Mm.
Pulmonary.
Heart failure.
Yes, sir. Yes, ma'am.
Hmm.
There is, do you know what is post-tussive suction?
Yes, yes, sir. In cavity with in a large cavity,
Mm.
when we auscultate over the cavity, when we ask the patient to cough, we can hear a suction kind of sound. So,
No, no. Once the patient coughs and again takes a deep breath, then the collapsed cavity would open. So that
oh,
would give
okay,
you a sound, and that is called as post-tussive suction, inspiratory suction.
sir. Okay, sir.
Okay. So
Now, another close differential, Dr. Varun, 1 second. Close
yes,
differential for the crepitations also, subcutaneous emphysema,
yes.
Yes,
especially in a person with a respiratory system examination case. Patient might be on ICD, might have got some leak of the air into the
yes,
subcutaneous plane where you have missed out palpatory finding of emphysematous changes subcutaneous plane, and auscultating might make you to feel that you're dealing with often mistaken for crepitations from the airways, or you're misinterpreting that for pleural rub also. So
yes,
always a careful examination in a person with ICD, suspecting mediastinal disorders, suspecting especially air collections in the pleural cavity. Always carefully palpate for the cutaneous areas, not only for the tenderness, not only for the intercostal space, but also for the signs of any evidence of emphysema subcutaneously in the form of crepitations, which will be much appreciated palpation wise as well as auscultation wise. Okay.
okay, sir.
Any other advantageous sound you can palpate?
So, crepitations in case of bronchiectasis, we can, as a tactile parameters, we will be able to.
Anything else? Sometimes pleural rub also very superficially can palpate.
Okay, sir.
Also can be palpable. Okay, when you're asked about differentiating between the crepitations and the pleural rub, always start from the nature of the crepitations versus your rub, especially how the sound, superficial deep sounds, and what is the pitch of the sounds, something like that you should start talking about. Okay. Yeah,
Okay, sir.
over to the faculties, please.
And when you were describing the oscillatory findings, no? So
Yes.
always first describe the whether the breath sounds were heard or not. Next,
Okay, sir.
the type of sounds, added sounds, and then hello, am I audible?
Sir, so your voice got cut, sir.
Yeah, yeah. So whether the breath sounds were or not, any
Yes, sir.
advantageous sounds were there, and then the vocal resonance. I think when you
Okay.
were describing, you mentioned about the vocal resonance before the added sounds, right?
Yes, sir.
So it's better to
Last
do,
vocal
yeah.
resonance.
So,
Yes.
so describe the added sounds and then come to the vocal resonance.
Okay, sir. Okay, sir.
Okay. So with this, you have come to a conclusion of bilateral bronchiectasis and left pleural effusion.
Yes.
Okay.
Dr. Rashmi Priya, what is the age of the patient, doctor?
80, sir. 79-year-old female.
Oh, 17-year-old.
Yes.
Suppose young age is coming to with this clinical findings of the oral candidiasis. Anything else extra history you'd like to ask for? And anything else extra etiology you can think about as a cause for this clinical presentation of this patient?
Any congenital syndromes the
Like
patient might be suffering from? Uh, candidiasis.
What congenital syndromes?
Any immunodeficiency, Shediac Higashi syndrome is
Okay.
associated.
Immunodeficiency is fine, right? What is celiac Higashi?
It is a type of immunodeficiency, the recurrent pulmonary infections.
Because of
Due to what?
because of what?
Go and read about inherited pattern of your bronchiectasis as well as immunodeficiency status coexisting with the bronchiectasis. Go and read about that. Okay.
Yes. Yes.
Yeah, please.
So, sorry, you had mentioned that in between you were mentioning that patient had some loculated effusion, no? I
When
mean,
we
you
are
were mentioning about loculated effusion. So, in this particular patient, how did you rule out that it is not a loculated effusion?
Mm, I'm not sure, sir. Loculated.
In other words, any particular sign you will elicit in cases of hydropneumothorax?
Yes, sir. Hydropneumothorax, we have succussion splash, sir.
Mm.
Then coin test
Mm.
and this
No,
flicking.
one particular sign which will not be there in a loculated effusion, but it will be present in a hydropneumothorax. What sign is that?
Scratch. Is it scratch test? I'm not sure.
What are the three S's?
Shifting.
Two yeses you have told.
What is the third?
Shift. Shifting dullness, succussion splash, and
Yeah, it is shifting dullness.
no,
Okay,
straight
so
line. Yes, sir.
yeah,
Shifting
right.
dullness.
So this particular patient, did the patient have a shifting dullness?
No, sir.
No.
I couldn't elicit shifting dullness, sir.
Okay, fine. So
Might
this
be
is
because maybe the amount of effusion was less. I'm not sure. It's
okay. So
not.
what is Ellie's S-shaped curve?
On percussion, there is a higher level of dullness elicited over the axillary region when compared to the anterior and posterior chest, sir. A similar curve can be noted on X-ray also, sir.
Okay, so did
It's
this particular patient have that?
Yes, sir. I elicited the dullness around sixth rib in the axillary region, sir, while it was around seventh rib in the anterior chest, left anterior chest, and around the eighth rib in the posterior anterior chest, sir.
Okay, so only one intercostal space difference
Yes, sir.
in the axilla, right?
Yes, sir.
Okay. So I'm saying that it is just the pleural thickening.
Okay, sir.
No. How will you
How will
differentiate?
you prove him wrong or right?
Hmm.
What findings in your these things would suggest that it is a pleural effusion rather than a pleural thickening?
The decreased
Hmm.
intensity of breath sounds,
Pleural
sir.
thickening can also have diminished breath sounds, diminished chest movements, decreased breath
Vocal,
sounds. Hmm.
vocal resonance. Vocal resonance is decreased, sir.
How is that
It as
different
well.
from the effusion?
That is also thick
Hmm.
pleural still. Uh,
Which would
Sir,
differentiate?
just about the maybe just about the effusion dullness, so we can elicit a bronchial, a hyperresonant note, sir.
Okay. That will
Can
be
be.
in effusion, huh?
Yes, sir.
But you didn't mention like that, no?
In this patient, I couldn't differentiate, sir.
Okay.
Mm.
So mostly,
How will you differentiate? What will change when I mean, how can you make the fluid move?
When shifting dullness, but
Yeah. No, shifting dullness. See, in hydropneumothorax, the shifting dullness would happen immediately because there is an air fluid interface. Once the
yes,
patient changes in position, the fluid level also would change, and then the area which was stony dull initially would become resonant,
resonant. Yes,
hyperresonant because of the air.
yes, sir.
Whereas, even though the patients with pleural effusion may not have shifting dullness immediately,
Yes, sir.
if you give some time, over a period of time, that fluid will gradually move to another position. So the place where it was initially dull would become resonant. Okay,
Yes,
you got
yes,
the point. Whereas in pleural thickening,
yes.
this is not going to change, right?
Gosh.
It's
Yes,
going to stay dull even though the patient changes in position.
yes,
Okay.
So how
yes.
will you, what is the gold standard to prove one or the other?
Shifting dullness, ma'am.
No, gold standard is not there.
Gold standard.
I mean, whatever you want to say. What is the proof of this? That is pleural thickening versus fluid. Paracentesis. Yeah,
Yes, ma'am. Yes, ma'am.
but no other way, right?
Yes, sir.
Regarding
Now,
the pleural
on
effusion, the change in the note usually takes 3 to 5 minutes for you to wait for the shift of the fluid. That's what the standard textbooks of clinical medicine says. The 3 to 5 minutes you have to wait, which is
Okay.
not practically, it's not practically possible
during
exam
exam.
point of view, because only given time is 15 minutes for you to finish off. Because
Yes,
exam, MD exam, Dr. Varun's only 15
Yes.
minutes for them to short case. It
Yes,
is
sir.
not a
Yes.
long case for them. So
Yes, sir.
naturally,
So they may not
what
have
they,
time to
yeah.
change the
You have
position
to
also.
wait for 5 minutes to wait is not possible.
Yes, sir. Yes,
And
sir.
another point you mentioned about Dr. Lakshmi Priya regarding the above the level of pleural effusion, resonant node will be hyperresonant. Usually the signs which is expected is can get bronchophony just above the level
yes,
of pleural effusion, can
yes,
get bronchial breathing also because of
yes,
the partially collapsed underlying airways, can produce this type of positive signs, may not
yes,
be having the hyperresonant note as it is as a sign just above the level of pleural effusion.
yes,
Unless you have this collection of air, then you have the two different mediums, then you can get the hyperresonant. Otherwise, you don't get hyperresonant note. Yeah.
yes, yes,
Yeah. The 3S's now become 4S, which is included with scratch test also.
yes, sir. Scratches.
Yeah. Yeah. Okay.
Okay.
Yeah.
And ma'am was mentioning that you'll have to get a paracentesis done, right? As you
Yes.
are displaying your investigation slide, is there any investigation modality that can tell you
Fluid,
that it
yes.
is effusion or pleural thickening? Any imaging
X-ray,
modality?
chest X-ray, sir.
Okay.
Um,
So how would you differentiate between a pleural thickening and effusion in an X-ray?
X-ray, pleural effusion will cause blunting of costophrenic angles, sir. And if it's of a larger effusion, we'll see the meniscus differentiating the air and the fluids, sir. In case of pleural thickening, usually pleura is not visible on an X-ray. So if you can see the opacity
Now,
of
if there is a thickening, it can still be seen as a CPA angle blunting, or it would resemble a pleural effusion.
okay,
So
sir.
one imaging modality that will confirm whether, apart from CT,
Yes, sir.
one modality that will confirm if it is a pleural effusion or pleural thickening.
What is it?
What modality is that?
No, no, no.
Yeah.
What we do all routinely before the paracentesis. And Nama.
X-ray.
No, okay, X-ray
No.
you've said. Anything
Yes.
else? Before a
CT.
CT.
Before
What
a
do we ask?
She said, mentioned, ma'am, ultrasound.
Oh, you said ultrasound. Oh, I didn't hear it. Okay.
Yeah.
Ah.
Yeah.
Oh, you said ultrasound. Sorry.
Yes,
Yes,
sir.
ma'am. So
Okay.
ultrasound would help you in
Ultrasound,
differentiating between, so it's
pleural thickening
I
and
mean the pleural thickening as well as the effusion. You can quantify, you can mark the site where you want to tap.
yes, sir.
There are certain signs which will tell if it is a empyema or not. So before putting in a needle, if it is a moderate amount of effusion, it is okay. Otherwise, it's
Yes,
better to get an ultrasound done so that you can
yes, sir.
know the quantity of effusion, what type of effusion it is or not. Okay.
Yes, sir.
Fine.
What is Grocko's triangle?
Grocko's triangle is a area of uh, area of resonance heard over the side opposite to the pleural effusion in the moderate to severe pleural effusion one. It is bounded medially by the line along the T10 dorsal vertebra and laterally posteriorly by the lower limit of lung resonance and laterally by the curve line joining these two lines.
Sorry, you've lost me. So it is an area of increased resonance or increased dullness?
I think
It is on
I
the
think
which
it's
side is
increased
it?
dullness
Suppose
one
you have a
because
left-sided pleural effusion.
yes, ma'am.
Where will
So
the
towards the right
Grocko's
side,
triangle be? On the right side or on the left side?
on the right side, ma'am.
On the right side. And what
Yes, ma'am. It will be
happens?
dullness, ma'am. Sorry, ma'am. It's
It will be
dullness.
dullness. Yeah. And it's a
Yes,
triangle as described in the word. It's a triangle. So how
yes.
is it formed?
It is formed in the medially along the vertebral, ma'am, around the T10 vertebra. Uh,
Hmm.
um, inferiorly by the lower limit of lung resonance, ma'am, and
Lower
laterally by
limit
the
of lung resonance. Hmm.
laterally by the line joining these two points, ma'am.
Um, why does it happen?
Because on the opposite side there is moderate to severe pleural effusion which is pushing the normal lung towards the opposite side.
Hmm. The posterior, mediastinal, and pleura. Hmm?
Yes, ma'am. Posterior mediastinal. Yes,
Okay, doc.
So
What else?
anything else in the inspection? I mean the examination, ma'am.
Uh, can't think of anything else.
It is not only the pleural effusion, you can get these signs in the opposite side, but also you can get ipsilateral, the collapsed lung parenchyma also can have certain findings also. Close to the vertebral body. Close to the vertebral body. Okay. So
okay.
both sides can get changes. Suppose massive effusion, the pleural push to the opposite side, pushing the mediastinum can have positive signs of the effusion on the opposite side. Similar to that, you can get collapsed lung parenchyma ipsilateral side also.
Yes, sir.
Okay, very important. Okay.
Yes,
And what is Boyer's sign?
sir.
Boyer's sign, BOAS, Boyer's sign.
Boas. Yeah. I'm not sure, sir.
It's also homework to all
Okay,
the
sir.
PGs those who are listening to the presentation discussion. Yeah.
Yes.
Okay. We'll go for some investigations and discussion on the therapeutics also, Dr. Varun and Madam.
Okay.
Yeah.
So,
Yes, sir.
what do you think is the etiology of bronchitis in this lady?
Uh, in this lady, ma'am, recurrent, as we mentioned, the recurrent respiratory infections can cause the prolonged secretion
Okay,
and
just will you classify? Can you classify the bronchitis? I mean,
sure.
etiology wise, etiology wise.
Uh, it can be congenital, ma'am.
Okay.
Congenital or acquired, ma'am. Congenital cystic fibrosis and ciliary dysfunction syndromes like immotile celiac syndrome, Cartagena syndrome, alpha 1 antitrypsin deficiency. Or it can be acquired due to probable necrotizing pneumonia, pulmonary tuberculosis, or some obstruction of the bronchus, either due to some growth or a foreign body.
Will that cause bilateral bronchitis? This is, you said bilateral, right?
In this patient, oh no, ma'am, no, ma'am.
Obstruction and all is
And
usually focal, right?
unilateral focal, ma'am.
Focal
Yes,
or
ma'am.
unilateral. Yeah. Okay.
Yes, ma'am. And
Right.
any rheumatological autoimmune diseases like
Hmm.
we discussed rheumatoid arthritis, SLE,
Hmm.
Sjogren's,
Hmm.
and any allergic
Hmm.
reasons like aspergillosis, allergic
Yes.
bronchitis.
Yes, certainly. Infections, don't forget HIV. Hmm?
Yes, ma'am. Yes, ma'am. That's right.
HIV. Oh, yeah. Then what else? Connective tissue disorder. Many patients, I think you would agree, Varun, that we don't
Huh?
really get a cause. What do you say?
Yeah, it can even be idiopathic.
Idiopathic.
Yeah.
At least no cause that we know of, right?
Mhm.
Yes.
It could be some old infection which the patient could have been unrecognized. So that
Yeah,
also is
yeah,
possible.
Yes.
sure.
Yes.
Right. Yeah. So how would you proceed further?
We went ahead with basic blood investigations, like complete blood count with peripheral smear. We had an inflammatory markers, renal function, liver function, and an arterial blood gas analysis to assess her for any hypoxia. We did sputum analysis, the basic gram stain culture. We check for acid fast bacilli and gene expert for mycobacterium tuberculosis, and also fungal culture. Then we went ahead with imaging, uh, chest X-ray and high resolution CT chest. She can undergo pleural fluid analysis to understand whether it's an exudative or transitive fluid. Another is serum LDH to support the for the pleural fluid analysis, and to rule out her cardiac part, to rule out any if there's any strain on the heart due to the lung pathology. Went ahead with ECG and echo. So.
So you have these.
Yeah.
Yeah. Okay.
This is her chest X-ray, sir. The chest X-ray is chest X-ray PA with an inspiratory film. It is adequately exposed. The trachea seems to be midline position. Uh, there is predominant dilated bronchioles and homogeneous opacities over the bilateral lower zone with the blunting
Bronchioles.
of uh, yes, dilated airways over. I can see over the right lung field towards the.
What is the classic description of that dilated called? I mean, how will you say it's dilated?
Compared to usually trachea, when we compare to the trachea and further on as the bronchi and bronchioles proceed, the diameter should be reducing, ma'am. Here we can see the diameter is on the almost similar to the
Compare it to what?
tracheal
To the vascular
tracheal
shadow.
shadow.
To the
Yes,
vascular
ma'am,
shadow.
tracheal shadow.
It goes by some name.
In this
The classical
bronchial
description of
arterial
the
that
X-ray, on plain X-ray, some
yes,
sign,
signet rings.
signature sign. Okay.
Yes.
So what are
Then
the other signs in X-ray for
tram
bronchiectasis?
track, tram track signs.
Okay.
Then then
So,
cysts.
so why do you, why, there are two types of opacities. One is tram track, and the other one is
Signet ring. No, opacities.
cystic spaces.
Cystic
Yeah,
spaces. Yes.
signet ring. Parallel lines, right?
Yes, sir.
Yeah, whereas cystic
Parallel lines and
spaces round opacities.
yes, sir.
So how are both different? Am I audible? Hello?
Yes, sir. Voice got cut soon.
Yeah.
Uh,
Okay. So
signet
basically,
ring.
tram track lines are side-on views of the airway,
Yes, sir.
of the dilated airway, whereas
Signet ring is that anteropo posterior because we're
yeah,
not able to see the
end-on view.
End on it's called.
Yeah,
end on.
yeah, that is
Yes.
called as end-on view.
Yes.
Okay. And any other sign? There can also be tubular opacity.
Okay, sir.
Is that when I think there is some
Hello, sir.
issue with. Just give me a minute, no? Just give me a
Yes.
minute. Yeah.
Yes.
Ma'am, you please proceed now. Just give me a minute.
Okay.
This left CP ankle blunting, ma'am. Left
Okay.
costophrenic ankle and cardiophrenic ankle blunting with
Right.
probable cavity over the cavity-like lesions over the left lower zone.
I am not able to see your slide now. I don't know what has happened. The slide has vanished. I can hear you.
Okay, ma'am.
It
Where
is
does it?
seen, madam. It is
Huh?
visible. It is visible. It is visible.
It's visible.
Yeah, visible, visible.
Why is this? Okay, I cannot.
Well, I can suggest Dr. Lakshmi, you can start describing these as the heterogeneous lesions also, occupying with the region of the lung parenchyma. Like
Yes.
you can say lower zone, mid zone, or upper zone, or all the three zones are involved. And what exactly the heterogeneous nature you're visualizing is to be described after which.
Okay, sir.
Because when you're going to see a shadow in any chest X-ray PA view, it always
Yes,
starts
sir.
with heterogeneous or homogeneous. As I said, definitely the costophrenic angle on the left side is obliterated, and a
Yes, sir.
lot of other changes which you're able to see.
Yes, sir.
And you're able to see the right side part also. The diaphragmatic shadow, if you see carefully, right side and the left side, it's a bit of literally bit of near flat line on the right side.
Yes,
Left
sir.
side, you're not able to see anything on the left side.
Yes, sir.
And the cut section, what you have taken is you're not able to see the gastric shadow also.
It
In
was
a
not
person of
visible. Yes, sir.
yeah, in a person of this nature also, you're supposed to look for the any evidence of situs inversus
Yes, sir. Yes, sir.
because you're dealing with a case of bronchiectasis, right?
Bronchiectasis. Yes.
And if you see the lung volume as it is, you're supposed to comment about the inspiratory film or expiratory film. But even then, the right side lung volume is more inflated than the left side.
Left side.
And if you see carefully, the left side lower lung volume is bit of contracted, whereas the upper part is relatively increased on the left side. So
Yes.
clinically, as well as the radiologically, what sounds to me is more of patient might have developed long-term disease, which has led
Yes.
on to some amount of emphysematous changes, which area also involved in this chest X-ray. That's the meaning of this. And definitely can understand the scapula medial border is completely within the lung parenchymal area. That means the positioning of the patient is not properly done. Yeah.
Yes.
And you're
Yes.
also able to see the prominent aortic knuckle here, as well
Yes.
as the pulmonary artery. Slightly, the positioning of the patient is also not proper because if you see the clavicular, sternoclavicular joint on the left side, more placed wide apart compared to the right side. It has gone completely inside than the left side. You're able to see that?
Yes, sir. Yes.
The medial end of the clavicle slightly moved away compared to the right side. That means the patient's positioning is not properly done. In that case, why I'm talking about that point here is we said about the trachea and the midline. Number two, I talked about the aortic knuckle prominence and other things, which will have this type of positioning will have a overshadowing shadow can be there,
Yes, sir.
which will give some sort of wrong interpretation. But before interpreting the mediastinal structures, especially the cardiac structures, including the vasculature, better to look at the patient's positioning and the patient's positioning in the sense medial border of the scapula, along with the sternoclavicular joint areas, how much it is placed, is it equidistant from the midpoint, that you have to look for that before making any comment. Okay,
Yes.
because in
Dr. Lakshmi,
situation of this, we are going to say right side is enlarged. For example, right cardiac border is enlarged or widened to say you're dealing with a pulmonary hypertension, cardiac failure, pulmonary. Those
Yes.
situations, if you are not able to see, there are so many reasons. Because you can see this right side is not that much enlarged. Probably it's a hyperinflated lung field is masking the right cardiac border also to some extent. But
Yes.
those type of changes, before interpreting and commenting to the examiner, have a close look and decide about are we going to give importance for this sign or not. Okay. Yeah. Dr.
Yes.
Varun, you
Dr.
ready?
Lakshmi, yes, sir.
Yeah, please go
Uh,
ahead.
so sir was mentioning the patient's position is not right, right? So can you tell
Yes.
me what has gone wrong here? The
So
spinoclavicular distance, which side is it? It is increased.
it's increased more on the left side, sir.
Okay, so in that case, what type of uh,
It's
poor
a rotate.
positioning would cause this problem?
Uh,
Basically,
rotation.
yeah, it is rotation
Yes.
towards right side or left side.
Uh, The right side is more rotate.
Now the patient has rotated towards the left side.
Left side. Yes, sir. The
So that is
right
why
shoulder
the
is towards
yeah.
the.
So that's why there is a increase in distance between the spinoclavicular distance.
Yes, sir. Yes.
And are you able to make out the left cardiac border
Yes, sir.
completely?
Is it clearly
Left.
visible?
No, sir. No, sir. Towards the lower zone, the cardiac border is not clear, sir.
Okay. So when do you get such what sign is it called as?
Something with S. I can't see the slide, but anyway.
Uh, so if the
Something
normal
is
anatomy is obscured with some other
Yes.
opacity, what sign is it called
What
as?
is it called? Something with S, Lakshmi.
Shad.
Not shadow. Ah, okay. That's not shadow. It's called something. It's the same word, but it's a different word. I mean, same meaning, but
You're not able to make out the
silhouette sign.
left heart
Left heart.
border as well as the diaphragm. It's called
Yes.
as the silhouette sign.
Silhouette sign.
Silhouette sign. Yes, sir.
Yeah, it's called as a silhouette sign. So if the left heart border and the left diaphragm is obscured, where exactly is the abnormality?
Towards the left lung, sir.
Yeah, left lung is obvious.
Yes.
Which lobe it is? So if the
Left
left
lobe.
heart border is obscured, see any abnormality which is closer to that particular structure, then only it will get obscured, right?
Yes, sir. Yes, sir.
So which lobe will be near to the left heart border? It's the lingula.
Left. Okay, sir.
So if there is any abnormality in the lingula, you can have obscuration of the left heart border. And if there is any abnormality in the lower lobe, your diaphragm gets silhouetted.
Okay, sir.
So here both the left lingula as well as the lower border is having infiltrates.
Yes, sir.
And is there a air fluid level there?
Yes, sir. The left lower zone,
Mm.
we're able to notice few air fluid levels are there, sir. Probable cavity lesions might be there, sir.
Cavity lesion. So that any cavity with air fluid level is called as?
Uh,
What do you call a cavity with an air fluid level?
this one, sir.
Hmm?
Sorry,
What
I'm
is
not
it?
getting the word.
Lung
Arey
abscess.
wow.
Lung abscess, right?
Virulent. Lung disease. Oh my goodness.
Lung.
Lung abscess.
Yes, sir.
Lung
Lung abscess.
abscess.
Lung abscess.
Yeah. So where else do you get air fluid level?
Sir, air bronchogram, that pneumonia,
No,
No,
no.
no, no.
No, I'm
Air
asking about
fluid.
air fluid level.
fluid level. Sir, in fungal.
See, it can either be in the parenchyma, which is lung abscess, or
Or
it could be in the
pleura.
pleura. What is it
Fluid.
called? If it is in the pleura, what is it called?
You just described succussion
Local.
splash, all that. Where is that seen?
Hydronomothorax.
Yeah, hydropneumothorax.
Pneumothorax.
So, uh, how will you differentiate an air fluid, I mean, lung abscess and a hydropneumothorax in a X-ray?
In hydronomothorax, it will be a straight line, sir.
Hmm?
And the lung above the fluid level will not have bronchovascular markings, sir.
Okay, you mean to say there can be pneumothorax
With
and yeah, with an effusion.
yes,
Okay, so I'll just tell this point. There is something called as loculated hydropneumothorax as well.
okay, sir.
So generally, if you take a lateral X-ray, if it is a
Yes,
hydropneumothorax, that air fluid level would extend from the anterior to the posterior chest wall. Okay, because that
yes,
is in the pleura. Okay, whereas if it is in the parenchyma, it will be restricted within the specific lobe. So that
okay,
is
sir.
one way of differentiating between a lung abscess and a hydropneumothorax.
Okay, sir.
Okay,
Yes.
fine.
So, what are
Uh,
the types of bronchiectasis, Lakshmi?
Ma'am, according to the shape of the bronchi, we can divide it into varicose type of bronchiectasis, tubular, and cystic, ma'am. Then, depending on the involvement of the lung parenchyma, it can be focal or diffuse, ma'am.
Okay, what does it look like, this one? Because I can't see the slide.
This
What does it
looks
look like?
diffuse, ma'am. Diffuse involvement.
Diffuse, you mean in all lobes?
Yes, ma'am. Right lung parenchyma, both upper, middle, and lower zones are involved. Predominantly on the lower zone, but upper and middle zone are also showing involved.
Okay.
And yes, ma'am.
Both bilateral.
Yes, ma'am. Yes.
So, if the patient has a bilateral bronchiectasis, based
Yes.
on the area of involvement, can you tell the etiology of bronchiectasis? Say, for example, if the patient has upper lobe predominance,
Yes, sir.
what could be the etiology of bronchiectasis?
It can be tuberculosis, sir.
Post-tuberculosis,
Post tuberculosis.
it can be because of cystic fibrosis.
Yes.
Okay, so when will a patient have central bronchiectasis?
Um,
ABPA will have a central bronchiectasis.
okay.
Lower lobes, recurrent aspiration, any childhood history of infection, any immunodeficiency. So these type of etiologies would have predominantly lower lobe involvement. Okay.
Okay, sir. Okay, sir.
So apart from the signs which you told, another thing is tubular shadows in X-ray. What is a tubular shadow for bronchiectasis?
Uh,
So if the bronchiectasis is filled with mucus plugs,
okay, sir.
you can see it as a tubular shadow. Any radiological sign,
Sir?
any radiological sign, it's called as finger and glove appearance.
Yes.
Okay, so that is because of mucus plug obstruction.
Okay, sir. Okay, sir.
Where do you get middle lobe bronchitis, ma?
In tuberculosis, ma'am, or any foreign body, there's a parenchyma compressing the bronchus.
Tuberculosis is generally, I think it's MAC, non-tuberculous
Non-tuberculosis,
mycobacteria.
ma'am. Okay, ma'am.
Oh.
In children also, tuberculous lymphadenopathy, right? Mediastinal lymph node,
Yes.
enlarged lymph node can cause compression of the middle lobe bronchus and can cause middle lobe bronchiectasis.
Okay, sir.
Okay,
Yes.
fine. So
When do you
What is
get
Bronx
tree in
syndrome,
bud
doctor?
appearance, ma?
Sorry, ma'am.
Tree in bud. To continue with what Dr. Varun asked you about finger in glove, no?
Yes.
Tree in bud.
The tapering of the bronchi uh, as the as we progress from the bronchi towards the bronchioles, the tapering of the lack of tapering of the bronchi. I think that sign is treatment.
that is not tree in bud.
That's not.
That's not.
Tree in bud is nodular opacities with linear branching pattern, which you would mostly see in CT scan, not in the X-ray. But actually the X-ray what you put here, no, it is looking. There are areas of bronchiectasis, but I feel more of cavitation is there.
Yes, sir.
Multiple small cavities.
Yes, sir.
Okay.
What
Predominantly
is
in the mid
Brock
zone and the
syndrome?
lower zone.
Yeah.
Brock syndrome is any so due to either tuberculosis or any foreign body compressing the middle bronchus, sir,
Mm.
within compressing the main bronchus, causing middle lobe involvement, sir.
Middle lobe involvement.
Yes,
Okay.
sir.
So Dr. Varun was talking about the cavity. How will you differentiate in a chest X-ray plain PA view or any view to say it's a cavity or emphysematous bullae? Because both looks like translucent lesions, right?
Yes.
How do you differentiate
Cavity,
this?
cavity
Yeah,
can have air fluid levels, sir.
not necessarily.
Infected bulla also can have an air fluid level. So basically what sir is asking is, it is all hyperlucent areas, both cavity and bulla.
Yes, sir.
Which characteristic feature would differentiate that?
Bulle versus cavity.
Cavity.
So when you look at the cavity, no, I mean any hyperlucent area, you should
Yes.
look at the size of the opacity, wall thickness. Okay, so based on the wall thickness, bulla will have a thin walled this thing.
Yes.
So less than a millimeter or more than a millimeter, very thin note is going to be a for bulle. Whereas 2 to 3 millimeters width is going to be seen for any translucent shadows. You can think about cavitating lesions, because when a person of this nature can get such a bloated or inflated lung, you can
Yes.
get some sort of changes extra other than the volume loss areas. You can get emphysema as bulle also. So more don't misinterpret that for this cavitating lesions also. You should know, but just telling a point for radiologically how to think about what lesion you are dealing with. That's all. Okay.
Okay, sir.
Yeah. Yeah.
Okay, please proceed, no?
The
Therapy
CT,
wise, yeah, CT scan. Okay. Yeah.
this like bilateral diffuse nodules and nodules with cavities in the both the lung parenchyma, sir, with the large cavities and involving the left lower zone, sir, along
Left
with
lower
bronchial.
lobe. When you're
Yep.
describing a CT, it is not zone, it is lobe.
Low,
Okay.
along with the bronchiectatic changes.
Okay. So on the right side image, no,
Yes, sir.
there is a classical sign. What can you tell me what sign it is? On the left lower lobe.
The air halo signs, sir. Reverse halo signs.
I'm talking about the left lower lobe.
Left lower lobe.
Mm.
Uh, the bronchioles are
See,
dilated.
left lower lobe, there is a large cavity,
Yes, sir.
right? Apart from that, there is large
Left.
area of consolidation.
Yes, sir.
Within that consolidation, you are seeing some black tubular opacities, no?
Yes, sir. Yes, sir.
What sign is that?
Reverse halo signs.
Reverse halo sign is,
Consolidation with the air shadows,
Cons-
doctor.
yeah, consolidation with air bronchogram. So that is a typical air bronchogram, what you see.
Okay, sir.
Okay, fine. So any other, see, with whatever images you have put, it is more of multiple cavities here.
Yes.
And especially with your clinical signs, what you had mentioned, with this big cavity, you should have got a cavernous breath sound.
Yes, sir.
Hmm?
It
Okay.
could be that the left pleural effusion could have masked the sounds.
Yeah, could be. And that is also possible.
Yes.
Okay, so where do you get a halo sign?
Uh, halo sign is usually seen in consultation, sir.
Seen it? No, halo sign is
Halo.
basically central consolidation
Yes, sir.
surrounding ground glass opacities.
Perfusion of.
That is called as
Yes.
halo sign.
Halo sign.
There is something called as reverse halo sign, where there will be central ground glassing and surrounding consolidation.
Consultation. Yes.
Yeah.
So, halo sign is a sign of which infection? You mentioned that in one of the etiologies of bronchitis.
Uh, fungal infections.
Yeah, which fungus?
Aspergillus.
Aspergillus.
Aspergillus. Yes.
So Aspergillus, mucor
Mucor.
can have this halo sign. Okay,
Okay, sir.
fine. So then so you have taken X-ray, you have taken a CT.
Yes.
What would you do next?
Sir, we'll have to see the sputum analysis if there's any, since we're suspecting any possible TB, if it's coming or it's positive, sir. If
Mm.
she's not producing sufficient sputum or we're not getting conclusive tests, we'll have to go for invasive methods like bronchoscopy and try to get bronchoalveolar lavage and analyze. Sir. Since this much cavities and nodules are there, so close differentials will be tuberculosis, fungal,
Mm.
can be malignancy also, considering her age and prolonged history.
Bilateral.
Yes, sir. Yes, ma'am.
Bilateral.
Malignancy.
No, I mean, I don't know. I've not seen the slides. I still can't
Uh,
get it. But so those nodules are bilateral.
Nodules are
Bilateral
bilateral.
cavities, man.
Bilateral cavities.
Cavities.
Is it?
Yes, ma'am.
So can you tell me some non-infectious causes of lung cavities? Hello?
Yes,
Am
sir.
I audible? Yeah. No.
Yes, sir.
Yeah. Non-infectious cavity.
Non-infective causes. So, any, not sure, trauma, sir, or related trauma.
No, one you were describing is malignancy.
Yes,
Yeah.
sir.
So, some metastatic tumors that can cavitate
Yes, sir.
could be vascular causes. Okay.
Vasculitis and vasculitis
Yeah,
can.
vasculitis, septic emboli can cause
Yes,
cavitation. Vaginous can cause.
vagus.
Okay. Yeah.
Yes.
So these are the other causes of most
Non.
common causes of non-infectious cavities.
Yes.
Okay,
Yes, sir.
fine. So especially this multiple small cavities with history of hemoptysis. Uh, did she have this thing, hematuria or anything?
No, sir.
No.
No,
Okay.
no high colored urine, sir.
Okay. Fine.
Which kind of systemic diseases we can get? Um, what do you call hemoptysis, bleeding, epistaxis, nodules, pulmonary nodules. It's systemic disease.
Uh, Vasculitis, ma'am.
Yeah, granulomatous with
Granulomatous.
Yes.
polyangiitis.
Polyangiitis. Anchor. Anchor cerebral vasculitis. Ma'am.
Mm. Fine. So
What other nodules did Dr. Varun asked you? No, what are the non-infectious causes? Which other systemic disease?
Malignancy, metastasis.
especially
Rheumatic.
rheumatic nodules also can
Don't
be there.
forget rheumatic.
Rheumatoid nodules.
Rheumatoid nodules.
Yeah.
Sarcoid. Sarcoid.
Sarcoidosis.
Yeah.
Yes.
Yeah. Sarcoid also can have nodules, but generally it won't cavitate.
Oh, it won't cavitate, is it? Okay.
No, man.
Um,
Right, so most of it has been covered now. So this particular patient, that's what we have done. I mean, most of the sputum reports, gene expert, everything has come negative.
I see.
Yes, sir.
Bacterial culture, everything is negative. We have done
Yes.
bronchoscopy as well, and
Gene
that
expert
has
was negative, sir.
BAL also things are negative.
Yes, sir.
So the cause of the nodules?
It is still under
Uh,
evaluation, ma'am. Actually, we
Okay.
have sent a mycoplasma panel,
Uh-huh.
nocardia, and it
Uh,
could chronic cavitating pulmonary aspergillosis also is possible. So we have sent serum aspergillus specific IgG.
uh-huh.
So for other bacterial culture, fungal culture, and cytology, everything has come negative.
Okay.
So it is still under evaluation.
Okay.
Fine, ma'am. So anything else, ma'am?
Mm, Okay. So etiology-wise, we are at a kind of dead end, right?
Yeah, so most likely it is infective,
Ah.
and vasculitis workup also we have sent.
Oh.
So
Okay.
with broad spectrum
Have
antibiotics,
you
she
come
has
across
clinically
any,
improved.
as is this kind of adverse effect of that, what do you call it? She had some Ayurvedic or some treatment for the. Have you come across lung involvement in CAM? Uh,
Drug induced, ma'am.
Complementary, yeah, drug, complementary medication. Have you come across?
Uh, less likely, ma'am.
Less likely.
Less likely.
Okay.
So another possibility is non-tuberculous mycobacteria, as we were discussing earlier.
MAC, lab.
Yeah, yes, ma'am. So in that also, like AFB smear can be negative. We'll have to wait for the cultures.
Cultures to come.
Yes.
So, but meanwhile, with broad spectrum antibiotics, she is clinically improving.
Improved.
Right.
Yes.
So we'll have to wait for the mycoplasma
Would
and
she
other.
be a candidate for biopsy?
If again, if the mycoplasma, I mean, mycopanel is negative, probably we'll have to get a biopsy done.
Mm.
But there is a high risk of
Yeah,
pneumothorax.
at her age also, no?
Yes, ma'am. So probably from the left lower lobe, we can take a biopsy. And there is dense consolidation.
EBUS is it or
No, ma'am. Like transbronchial lung biopsies.
that's is it?
Transbronchial. No, ma'am. Transbronchial lung biopsy.
Transbronchial.
That is again bronchoscopically can be done.
Okay, what are the other general measures you take, ma, for this lady?
Ma'am, frequent since she has production of sputum, ma'am, postural drainage with devices or chest physiotherapy.
Mm.
Then ensuring any clearance with bronchodilators.
Mm.
Then to prevent once the infective part settles, to prevent further exacerbations, vaccination.
Mm.
Some cases of antibiotic prophylaxis in certain cases with macrolides. Then
Don't forget nutritional
yes,
status.
yes, nutrition improvement, frequent adequate hydration.
No, you mentioned she's pale, all
Yes,
that. So
yes,
anemic. Yeah.
yes.
So can you tell me a contraindication for postural drainage in a patient with bronchiectasis?
The patient is hypoxic, hypoxemia.
Okay,
It
that
can
is
aggravate.
okay. That, that may not be an absolute contraindication because
Okay,
many of the patients with bronchiectasis can have respiratory failure as well, right?
okay, yes.
If it is an acute hypoxia, then you need not do it. Any other contraindication?
So local focal bronchitis, sir.
Why not? No,
Focal
that would not
bronchiectasis?
be.
Yeah, that is not a
What is
contraindication.
dangerous in this lady, which would make it a contraindication?
So if she's having active hemoptysis,
She already had one, right? You said
Yes, sir.
no.
Yes,
Was
yes,
it
ma'am.
major or minor hemoptysis?
Minor hemoptysis, ma'am.
so that's what actually in the
So
history
the
you
blood
should
tension.
mention all those things which you have
Yes.
not mentioned. And
It
any
is only
patient with
blood thinks.
bronchiectasis and hemoptysis, it is better not to do chest physiotherapy.
Okay, sir.
Wait till the hemoptysis settles and then you should do.
Okay, sir.
Okay,
Okay, sir.
fine. So even though this is not a classical bronchiectasis alone,
Yes.
so let us like couple of questions pertaining to bronchiectasis. Uh, what are the ways of mucus clearing techniques you know?
Uh, Sir, and how we have to,
Assisted
how we can,
cough techniques or
uh,
mucus clearance techniques.
chest percussion, sir. Then
Okay.
using Ultrasonic devices, vibration vest,
Okay.
flutter valves.
Mm.
Then
What is a flutter valve?
it's a. I'm not very sure. So it was the. It
Okay.
helps when the.
It's called as an a cappella device.
Okay, sir.
Okay, so it helps in clearance. You read about it.
Yes, sir.
Okay. Fine. Um, Anything else, madam?
Yeah, would you
Already
like to?
10:15.
Um,
You
I can't really think.
Madam and Dr. Varun, can you
yes.
please give some input or feedback to the presenter's presentation skill, because the exam, basically the exercise is done for exam point of view.
Okay.
So we need some input to the presenter so that she improves the quality of presentation next time and even the examination also. Just input regarding the quality of presentation alone and answering your discussion also, both.
Okay. One thing I would point out, Lakshmi, is see, you try and have anatomical continuity when you mention it, in your presentation. And see,
Yes, ma'am.
infraaxillary, don't go from suprascapular, You know what I'm trying to say?
Yes, ma'am.
Lump them together so that it's easy for when I saw your slide, I had to
Yes, ma'am.
search to where it was decreased. Do you know what I'm trying to say? That
Yes, ma'am.
slide where the
The
um,
tables.
percussion note was dull and all that on the left side. Huh?
Yes, ma'am.
It looks anatomically, I mean, it looks discontinuous. I
Okay.
know you said it correctly, but
Yes, ma'am.
you write it, bunch it together, so it makes it more easy for the examiner to read. Hmm?
Yes, ma'am.
And of course, you won't have the luxury of such so much
Presentation.
time.
Yeah.
So that
So
you have.
whenever you're telling, no, you tell the abnormal area first and then you tell the normal area.
Okay, sir.
On the contrary, when you're describing percussion, you tell the resonant area first and then the abnormal resonant area.
Okay, sir.
Okay. So because when it comes to the exam, it's not going to, you'll not be putting a table like this. You will be
Yes.
describing, right? So
Yes, sir.
abnormal area first, followed by normal area. Whereas percussion, normal, when resonant percussion first, followed by abnormal percussion.
Yes.
Okay. And the other point is history, uh, which I was mentioning earlier also.
Yes.
So
Yes.
if it is within the duration of your presenting complaints, you should mention it in the history of presenting illness rather
Yes.
than mentioning it in the past history.
Yes.
Okay. So and other symptoms also you should describe it in
Yes.
detail.
Yes.
Okay. So otherwise you have taken you presented well.
Yeah, I think so. Reasonably comprehensive,
Yes. Yes, ma'am.
and
Thank you.
yeah,
Thank you, sir.
good.
And a few other tips to you, Dr. Lakshmi Priya. The other than the other faculties mentioned, what I found out is the basic questions of undergraduate level, you are not in a position to answer in a flow manner.
Yes,
For
sir.
example, hydropneumothorax. It's been a common teaching to tell the students 3 years, 3 years, and you are not able to come out with. And few other areas of questions, for example, if you get a cavitating lesion with the fluid level, what you call, you're not able to tell abscess. So something, just telling an example, one or two examples here. So basic questions, probably thought block. This should be overcome. This type of presentation skills will make you to get overcoming this problem. So that the
Yes.
exam point of view just immediately comes out. Because exam
Yes.
point of view, MD level, what is expected is you should talk a bit of in a flow manner for undergraduate level. When the level goes up one step above that, then if you're having some sort of hiccups, it's acceptable.
Yes.
But you are able to tell some answers very nicely on the contrarily, whereas the undergraduate level questions, your bit of hiccups were there, which should be avoided. Probably because
Yes.
of this or thought block in the club, but just to overcome that, it should be fine. Probably the overcoming this is by repeated presentation, repeat listen to the questions, and make yourself becoming more of reflex phenomenon. Yeah.
Yes.
And
Yes.
another important tip, exam point of view, since it's going to be MD exam, only 15 minutes given to you. So definitely you don't have this means the pleasure of writing so many points, and no, don't just you have to scribble here and there points alone. But important thing is you try to spend the conventionally steps to be followed, but only point suggest is try to spend extra time at the back than at the front. You'll get a more information because
Yes.
you're going to cover up all the three parts of your lung, parenchyma, and the pleura also. So then to spend extra time. So if you're going to spend 15 minutes for example, 12 minutes for examination, you try to spend at least 6 to 8 minutes at the back and 3 to 4 minutes in the front, so that you have some 2 minutes for recollecting the points, so that you don't miss anything, and you'll also get reasonably decent conclusion. If you're going to spend anteriorly more time, sometimes you might miss the important diagnosis at the back also. So this is one or two tips for you to exam point of view. But as an exam, other than that, you should spend more equal time only. Overcoming this time constraints in the exam, just making you to give it means tips only. Okay.
Yes.
With this in mind, probably anything else, Madam and Dr. Varun, to add to this presentation, or can we
No,
conclude it?
really.
Nothing
I,
much, sir. She has
yeah.
done a good presentation, apart from
Yeah.
the points what you have described. So
Yeah.
probably over a period of time, when she get trained with such presentation, she would do well in the
Yeah.
exams.
Correct. Correct.
Yeah.
Mm. If nothing to add, I think thank Dr. Sujay Menon, Madam, and Dr. Varun for wonderful discussion on this historical aspect as well as the examining the steps and the therapeutic point of view. I thank both the faculties for sparing the time to teach the students our virtual program. And I also appreciate Dr. Lakshmi Priya for wonderful presentation. And thank every one of you for joining this evening. And good night to all of you. Thank you.
Thank you, Sarvan, and good
Thank
night.
you.
Thank you,
Thank you.
Varun.
Thank
Bye.
you, ma'am. Thank you, sir. Thank
Ma'am.
you.
Thank you, sir.
Yeah.